2 minutes. I'm sharing the
Okay.
screen. Yeah. Is my screen visible to everyone? Is my screen visible to everyone?
Yes, ma'am. Now it's visible, ma'am.
Yeah, okay. So, good evening, everyone. The today's session is the pain management, which is the step one of WHO ladder and the adjuvants along with it. So, I'll be starting my presentation with a statement that pain is what the patient says that it hurts, not what we think that the patient is in pain. It especially holds true whenever the patient has chronic pain and when the vital parameters specifically doesn't appear as compared to the acute pain where a patient has tachycardia, BP is high. These symptoms will not appear when the patient has chronic pain. So, whatever it is, whether it is acute pain or chronic pain, we always have to remember that the pain is what the patient says it hurts. We have to believe the patient about his or her pain. Coming to the WHO analgesic ladder, it was in 1986 that the WHO proposed the analgesic ladder for the cancer patients, which later was adapted for non cancer pain, for both acute as well as chronic pain. So, if we are using this WHO ladder, efficiently, it helps in reducing the pain related morbidity in approximately 70 to 80% of the patients. The original WHO analgesic ladder has got 3 steps. So, this was the original WHO analgesic ladder, where the step one is for the mild pain, step two is for mild to moderate pain, and step three is for moderate to severe pain. So, earlier, we used to go by stepwise. With the pain persists, we move up one step, and if the pain starts getting resolved, and or if we find the signs of toxicity or the side effects, we try to move down the one step. In the step one, we had got non-opioids with or without adjuvant analgesics. In step two, we have got mild. Just a second. For step two, we have got opioids for mild to moderate pain plus non-opioid with or without adjuvant analgesics. And for step three, we have got stronger opioids. Again, we can use non-opioid with or without adjuvant analgesics. So you have to remember, in any step, we can use NSAIDs along with the adjuvants. Coming to the principles of WHO analgesic ladder, the most important point are it has to be by the clock. That means we should not give some painkiller when the patient says, now I'm having severe pain. So we should be giving by the clock. That means you have to give round the clock by BD, by TDS, for example. It has to be by the mouth, orally, whenever possible. And third, it has to be by the ladder, depending upon the severity of the pain. And it has to be individualized, not randomly we can give. And last, we have to pay the attention to the detail. We have to find out the characteristics of the pain, the aggravating and the relieving factors, and all those things. Yeah. So the original WHO ladder was unidirectional, and no non-pharmacological treatment was added in the original WHO ladder. The updated ladder focuses on the quality of the life, wherein the fourth step is added, which includes the interventions like palliative radiation or epidural insertions or intrathecal painkillers. This can be used along with the strong opioids and it can be bidirectional as well. So for acute pain, we can start from the fourth step, and for chronic pain, stepwise approach is advised. In both the scenarios, de-escalation should always be kept in mind. So this is the original, and followed by it got transitioned into the another one modified WHO ladder where we have added the step 4. So this is the 4-step WHO ladder specifically for chronic non-cancer pain. Coming to the management of the pain, whenever we are treating the patient, we have to treat them with utmost respect and empathy. In the assessment of the pain, the first step is building a relationship. We should always listen actively, and we should always convey through verbal or non-verbal cues that we care, and we should promise them not something very impossible that pain is going to be from 10 to 0. If specifically we are managing chronic pain, we have to promise that we are going to do the best. Coming to the step 1 analgesics, they are used to treat the mild pain. It includes paracetamol and NSAIDs, which can be used along with the adjuvant drugs. The choice between the two should be based on the risk benefit analysis for each patient, as we'll see further. I'm starting with the paracetamol. In the paracetamol, predominantly, it has got central action. In the majority of the studies, they find that it has got COX-3 enzyme, which it inhibits in the CNS. Thus, it doesn't have any peripheral COX effect. Thus, we will see the less side effects with the paracetamol. It has got both antipyretic and analgesic action with no anti-inflammatory action, and it doesn't act on the peripheral COX enzymes. Coming to the dose recommendations, it is safe to be used at the dose of 12 to 15 mg per kg 6-hourly. We can go up to 3 grams per day. Oral dose has to be less than 4 grams in a day, and single dose should be less than 1 gram. And normal dose is 650 mg 6-hourly. There are also PCM sustained release tablets available. We can give them as well as IV as a 1 gram 6-hourly. We can also give paracetamol as a per rectal route when oral route is not feasible. It is safe for pediatric use in a dose again for 15 mg per kg 6-hourly. And the toxicity can be seen when we give the dose of more than 90 mg per kg per day. Coming to the NNT. NNT is the number of the patients who receive the drug for one patient to have a 50% pain relief. For example, we have started the treatment with the drug A, and we see that only after the 4th patient, the patient says that his pain has improved by 50%. So we say the NNT of that A drug is 4. So it is usually done with the long studies, in the systematic studies where we review all the analgesic drugs. Specifically for the cancer patients, there are not large trials done, but definitely we have got NNT of the various drugs and analgesics that we use routinely. So it is like inversely proportional. The less the number of NNT, the more efficacious is the analgesic. So if you see the NNT of paracetamol, it is 5. If you see the NNT of ibuprofen and diclofenac, which is around 4 or 3, it is not efficacious analgesic as NSAIDs like ibuprofen and diclofenac, but definitely it is a good important role in the chronic pain or acute pain as well as chronic pain as well. So what are the advantages and the drawbacks of the paracetamol? It definitely has a good safety profile. As I already mentioned, it doesn't act on the peripheral COX enzymes. So Any other undesirable effects which are very uncommon with paracetamol? It is well tolerated by the patients with peptic ulcers. It has got no adverse renal event and no effect on the platelet function, which is generally seen by the non-steroidal anti-inflammatory drugs. So it doesn't affect the plasma uric acids. We can give with the increased frequency. So the problem with paracetamol is it has the potential for hepatotoxicity. So in the high doses, it can, and with the impaired liver function, or the patient has chronic alcoholic, it can lead to hepatotoxicity. In those cases, we can give the patient paracetamol up till 2 to 3 gram per day only, not more than that. So what is the role of paracetamol in the cancer pain then? We still consider paracetamol as a mainstay of drug, even though its NNT is less, because it has found that it can be added to the other combination of drugs that are used in the WHO ladder and found to be very beneficial because of its safety profile and opioid sparing effect. So when it is added to the following drugs like NSAIDs, its NNT improves to 2. So it acts as a good and effective analgesic. It can also be added to the tramadol and opioid, specifically in every step of the WHO ladder. Let's come to the NSAIDs. Non-steroidal anti-inflammatory drugs are the heterogeneous group of drugs which produce their analgesic effect through inhibition of isoenzymes like COX-1 and COX-2 cyclooxygenase enzyme. So NSAIDs are classified into two types, non-selective and the selective. Whereas non-selective interferes with both COX-1 and COX-2, the selective COX-2 interferes only with the COX-2 enzyme. So this is the prostaglandin synthesis, where we are seeing that any endothelial membrane has got phospholipids, and with the help of phospholipase A2, this results in the formation of arachidonic acid, and with the help of lipoxygenase enzymes, you can see there is formation of leukotrienes and cyclooxygenase enzyme. There are formation of cyclic endoperoxidases and various chemical mediators like thromboxane A2, PGI2, and prostaglandins. And there in this cyclooxygenase step, which is this enzyme which gets inhibited by the non-steroidal anti-inflammatory drugs. So, as I already mentioned, NSAIDs inhibit COX-1 and COX-2. COX-1 is usually the constitutive, which is already present inside the body. And COX-2 is inducible for any inflammatory response whenever the body receives. COX-2 is constitutive and it is present in the kidney, gastric mucosa, endothelium, and the platelets. So, what were the side effects? Sorry, whatever the side effects we are going to see of NSAIDs, whatever the side effects we are going to see of NSAIDs are all because of this COX-1 constitutive enzyme, which are present in the kidney, gastric mucosa, and the platelets. Coming to the non-selective NSAIDs, they inhibit both COX-1 and COX-2. This includes ibuprofen and naproxen. Ibuprofen can be given per orally in the dose of 400 mg, 6 hourly or 8 hourly, with a maximum of 1 to 2. As you can see, the NNT of ibuprofen is 2. Coming to the naproxen, it can be given 250 to 500, 12 hourly, per orally or suppository, with NNT of 2.7. Selective COX-2 inhibitors, they inhibit COX-2 selectively, whereas their example is etirocoxib and celecoxib. Diclofenac sodium has also the propensity related to more COX-2, but it is also includes in the non-selective COX enzyme inhibitors. Diclofenac can also be given per orally and IV. It is also given per rectally also. The NNT of diclofenac is 2. The other routes apart from the IV oral is so NSAIDs can be given IV, it can be given oral, it can be given per rectal, We can also them use as a topical. It has found in the form of gels, creams, and sprays, and it has found that it has got less risk of systemic absorption and toxicity. For example, ibuprofen, diclofenac, piroxicam, and ketoprofen comes also as a topical NSA, and it can also be used as a transdermal route in the form of diclofenac patch, which comes as a new patch. This is the table showing the routine doses for the NSAIDs in the oral form, where diclofenac has got a dose of 50 mg TDS, ibuprofen in a dose of 200 mg TDS per orally, celecoxib can be given up till 200, naproxen 250 to 400 mg BD, and ketorolac can also be given subcutaneously also and IV also. This is just the table for you all to go through, where we can see that paracetamol has got minimum plasma protein binding with no GI erosion risk, no coronary event in stroke. Ibuprofen has got maximum GI erosion and coronary events risk. Ketorolac has minimal coronary events with maximum upper GI erosion risk. And diclofenac also have got coronary risks. Naproxen has been found among all to be the cardiac safe drug. That is important to remember. Whereas if you see the selective COX enzymes inhibitors, celecoxib and heterocoxib, they again have got maximum coronary event risk with minimal upper GI risk. Coming to the side effects of NSAIDs, if we know the constituent, where is this COX enzyme constitutively present, we know it's all going to affect those systems. So in the GI tract, it can cause gastric erosions, bleeding, perforations, and pain and nausea. In kidney, definitely it can cause, even a single dose in a susceptible patients can lead to AKI. It can lead to water and sodium retention, edema, hyperkalemia, and decrease effectiveness of the antihypertensive drugs and diuretics. In the CNS, it can lead to vertigo, dizziness, headache, and it can also lead to the inhibition of the activation of the platelet function, which is reversible, whereas if we see the aspirin, it is the irreversible inhibition of the platelet activation. And in special areas of hypersensitivity, it can also lead to rhinitis, bronchial asthma, flushing, hypotension, and also shock. So how we are going to select the NSAIDs? We have to see first that the patient has got a GI risk factor or not a GI risk factor. So in what are the GI risk factors? It includes the age more than 65 years, previous history of peptic ulcer disease, with any concurrent medication like aspirin, warfarin, and SSRIs. These patients are considered as a high-risk GI risk factors. So in those cases, you have to further divide whether the patient has got any cardiovascular disease or patient doesn't have a cardiovascular disease. In case of a non-cardiovascular disease, we can still give non-selective NSAIDs in a case of low NSAID GI risk factors. And if there is a GI risk factor with no cardiovascular disease, we can give selective COX inhibitors with or without PPIs. With the patients with the cardiovascular disease, we have to look for any alternative analgesics, then a non-selective NSAID, because a selective NSAID has got more cardiovascular disease risk propensity. Or if the patient had got again NSAID GI risk factor, we have to consider any alternative analgesia first. After the NSAIDs, including paracetamol, we are going to adjuvants. What are the adjuvants? So these are the drugs which are beneficial, which have got a beneficial analgesic effect despite not having been developed as a primary analgesics. So they're also called as co-analgesics. In adjuvants, we will see a vast variety of class of drugs that were primarily initially used for some other purposes, but later on found to have an analgesic role as well. Earlier, we used to think that they are not used as a first line, but just as in together with the painkillers, with other painkillers like paracetamol or NSAID. But now we know that in certain pain conditions like neuropathic pain, they are used as a first line treatment as well. So the advantage is that they facilitate better pain control with reduction in analgesic consumption as well as the concomitant side effects. This is just the classes of adjuvants which are used. Right from the multi-purpose adjuvants analgesics, we have antidepressants like steroids and alpha-2 adrenergic agonist like clonidine. In adjuvant analgesics, which are used for neuropathic pain, as I already mentioned, they are used as a first line, which includes carbapentinoid anticonvulsants, again antidepressants and corticosteroids, and other drugs as well, like baclofen and cannabinoids. We have got topical analgesics like caspacine, local anesthetics, again NSAIDs can be used as a topical analgesics, and tricyclic antidepressants. In adjuvant analgesics, which is used for bone pain, we have got steroids, we have got radiation therapy, and we have got calcitonin and bisphosphonates also. And for bowel obstruction, we have got anticholinergics, octreotide, corticosteroids, and adjuvant analgesics used for the musculoskeletal pain like muscle relaxants. So I already mentioned that they are co-administered with analgesics, but they are indicated as a first-line treatment for specific pain condition. For example, as I mentioned, first line in neuropathic pain, it's carbapentins, and other painful conditions like fibromyalgia, duloxetine, pregabalin again are used as a first line drugs. Coming to the antidepressants. The mechanism of antidepressants in the management of neuropathic pain is very unclear, and we know that whatever the dose is used as an antidepressant, less than that is used as for the analgesia. And it is analgesia is achieved at a faster rate, usually within a few days, than what we see as the onset for the antidepressant effect, which usually takes up to 6 weeks. So it is important to highlight that the pain relieving properties of antidepressants are independent of any effect on the mood. So the two main groups of antidepressants which are commonly used are the older one, which are tricyclic antidepressants, and the newer selective serotonin reuptake inhibitors and serotonin noradrenaline reuptake inhibitors. So what about the tricyclic antidepressants? They are recommended as a first-line drugs for the treatment of the neuropathic pain. It can be given at a dose of 75 mg per day, but we have to start at a slow dose. And especially, we have to be very careful in the elderly patients when we are using TCAs because it has got a high risk of anticholinergic and the sedative side effects, especially in elderly patients. Also, we have to avoid tricyclic antidepressants in a cardiac patient where they have found that sudden cardiac arrest has occurred at a dose higher than 100 mg per day. TCAs are further divided into secondary amines and tertiary amines. The secondary amine has got less side effects than the tertiary agents. In secondary amines, we have got desperamine and nortriptyline, and tertiary agents are imipramine and amitriptyline. Whenever we are starting the treatment with drugs like antidepressants, we have to counsel the patient beforehand that it is going to take few days, as well as it is going patient are going to face few side effects because it is often seen Because of the side effects, patients stop taking the treatment altogether within a week. Because of the side effects, like patient starts feeling dizzy, patient had got dry mouth. So we have to consult them beforehand that to have a little patience, and it is going to get better as the duration of the drug is increased. So TCAs are usually contraindicated in those patients with recent MI, arrhythmia, in mania cases, and those taking MAO inhibitors. And it should be used in caution with the glaucoma patients. It comes in tablet forms as well as comes in the syrup form. We have got 10 mg preparation, 25 mg, and 50 mg. And in syrup form, we have got 25 mg and 50 mg per 5 ml. So we have to start with the low dose in the form of 10 to 25 mg midnight night, which is scheduled at usually at it's given at as an HS. We have to slowly titrate as tolerated. And especially we have to be very careful whenever we are titrating the doses of the amitriptyline because of the side effects. And definitely, if benefit is not seen after 4 to 6 weeks, we definitely have to shift over. The side effects include dry mouth, constipation, blurred vision, urinary retention, tachycardia, and delirium also. It can also lead to orthostatic hypotension, can also lead to QT prolongation, and other side effects include sedation, sexual dysfunction, excessive perspiration, and the weight gain. This is the NNT for the drugs for the neuropathic pain in adults. We have got tricyclic antidepressants with NNT of 3.6, SNRI with 6.4, pregabalin 7.7, gabapentin 7.2, strong opioids 4.3, and tramadol 4.7. Important to note that this is the NNT for the individual drugs. So whenever we are preferring to combine the two drugs, the NNT of the individual drugs reduces. Coming to the SSRIs and SNRIs. These classes of antidepressants, they act by selectively inhibiting the presynaptic reuptake of serotonin and noradrenaline. SNRIs are usually preferred as an analgesics, whereas they have found SSRIs they have found much of the benefit. So SNRIs, we have got duloxetine and venlafaxine. They have the advantage that they are generally safer to use than TCAs. The adverse effects which are seen with SNRIs are the nausea, dizziness, drowsiness, constipation, and as well as dry mouth. Even in some cases, patients on duloxetine have complaints for insomnia. So, in those cases, we have to make sure rather than giving it the night dose, we have to give the drug in the morning time rather than in the night time because of the side effect like insomnia, which is though not very rare, but it can occur. Again, duloxetine is contraindicated in those taking MAO inhibitors and also should be used in caution with the glaucoma. These are the recommended doses for the neuropathic pain management. So, first line is tricyclic antidepressants, SNRIs, and anticonvulsants like pregabalin and gabapentin. As you can see in the first line, there is no NSAIDs, there is no weaker opioid and no strong opioid. This is the adjuvants which are acting as a first line drug. In the second line, we have got lignocaine patches. It is specifically very much recommended for the post-herpetic neuralgia. What we can do is we can use 1 to 3 patches to the region of the pain once a day for up to 12 hours. Capsaicin can also be used as a high concentration patches, but is only recommended for the peripheral neuropathic pain only. And in the second line, we have got tramadol. In third line, when all the treatment has failed, we can go for the stronger opioids as per the individual titration. Coming to the anticonvulsant drugs. Anticonvulsants, they act through variety of mechanisms to depress the synaptic transmission, elevate the threshold for repetitive firing of nociceptive neurons, and reduce the discharge from the dorsal root ganglion cells. This includes gabapentin and pregabalin. Both of these drugs, they bind to the voltage-gated calcium channels in the dorsal horn and decrease the release of excitatory neurotransmitters like glutamate and the substance P. Pregabalin has got a higher affinity for the presynaptic calcium channel, and almost they have got a same side effect profile, which include dizziness, drowsiness, peripheral edema, and dry mouth. Gabapentin is administered usually TDS and pregabalin is administered BT. And we have to remember in patients with renal impairment, both of these drugs doses has to be modified and adjusted. Coming to the anticonvulsant drug preparation, these are again comes in the capsule and in the tablets form, where the maximum dose recommended for gabapentin is 1.8 gram. It has gone up till sometimes up to 2.4 also. And in fact, it has gone sometimes, in fact, up to 3 gram also. Whenever we are increasing the dose, we have to always remember that side effect profile has to be checked whenever we are increasing the dose this much high. And pregabalin, again, it comes in the capsule as well as the oral solution formation. The starting dose is 50 to 75 mg BD, and definitely again we have to start at a lower dose. And in elderly and in the frail patients, we have to start even at the lower dose. Coming to the topical analgesics. Topical agents, they work locally, directly at the site of application with minimal side effects. As we saw that lidocaine was coming in the second line treatment for the neuropathic pain. So topically, again, it acts through the inhibition of the voltage-gated sodium channels. The side effect with the patches is only the mild skin reaction, and it can be used safely. We can use up to 3 patches a day for the maximum of 12 hours that can be used to cover the painful area. But we have to remember these recommendations, these are not for the cancer patients. These are mostly for the peripheral neuropathic chronic pain conditions. Coming to the capsaicin, its mechanism is related with the elevation of the pain threshold by reducing the amount of the substance P available to act as a neurotransmitter. Capsaicin is available in 0.05% or as a 0.025% cream, or it is also used as a high dose as an 8% batch. We have to remember whenever we are applying high dose concentration for the capsaicin, we have to apply with the gloves and according to the instructions. Can you give me a moment, please? I believe you might be getting some sound in the background. Just give me 2 minutes. I'm extremely sorry. Yeah. Coming to the capsaicin, I've already mentioned. Now coming to the corticosteroids. Corticosteroids, these are one of the drugs which are included at each step of WHO analgesic ladder whenever we are considering that anti-inflammatory effect is beneficial. They also have a role in specific clinical scenarios such as spinal cord compression and brain metastasis and bowel obstruction, where improved analgesia is a secondary benefit from the primary indication of reduction of peritoneal edema. These are the steroid doses and equivalent doses. Dexamethasone can be given as an oral IV as well as subcutaneous administration. Prednisolone can also be given as an rectal. Hydrocortisone and methylprednisolone can be given as an IV form, IM formulation as well, apart from the oral and IV administration. Coming to the bisphosphonates, these are usually as a standard therapy for the hypercalcemia patient and for the prevention of the skeletal events in some cancers. It is also used in the bone metastasis, but we have to remember that they are not used as a first line therapy. They are only used when the primary main therapy for the bone pain has failed. The adverse effect of bisphosphonates include renal toxicity, so we have to be very careful whenever we are starting the bisphosphonate therapy. It can also cause hypocalcemia, and not an uncommon side effect is osteonecrosis of jaw. So, how to reduce that risk is by a dental assessment prior to the treatment of the bisphosphonates and avoiding invasive dental treatment when the patient is on the IV bisphosphonates. We have to reduce the dose in the renal impairment. And it is very common that the patient will experience flu-like reaction when we are starting with the bisphosphonate therapy. And within 14 days, its analgesic effect can be seen. These are the main 3 bisphosphonates which are used, which includes disodium palmitronate, zoledronic acid, and evandronic acid. Coming to the baclofen. Baclofen, it comes in the mechanism that it binds to the kappa B presynaptic receptors within the brainstem, dorsal horn of the spinal cord, and other CNS sites. It is effective for the spasticity, trigeminal neuralgia, neuropathic pain in cancers, also in the refractory hiccups, in musculoskeletal spasm. We have to start with a dose of 5 mg PD or TDS, and we can increase up to 20 mg TDS. Half-life is 2 to 4 hours, but the availability is more than 90% per orally. It can be given orally, topically, as well as intrathecal pumps can also be used, especially in the cerebral palsy patients where the patient has got very severe lower limb spasms. So in those cases, intrathecal pumps have been used. The last table I have added is regarding the NMDA antagonist, where sometimes in very refractory cases where all the pain management has been used, ketamine infusion comes in play. We have to remember this is not given at home. It is patients are usually hospitalized for that. It has got various IV and the subcutaneous regimens, and there are IV burst doses. There are got continuous infusion doses for in the dose of 0.05 to 1.5 mg per kg per hour. So boluses can be used as a 0.25 to 0.5 mg per kg, whereas the burst dose is given as 100 to 500 mg per kg per day for 2 to 3 doses. It is also be used in very rare instances, though very uncommon in India, in the oral dose formation also. Again, we have to be very careful, and it is usually contraindicated in patients with the cardiac diseases. It can lead to hypertension, tachycardia, tremor, nystagmus, myocardial depression, hallucination, vivid dreams, and tonic-clonic movements. The next drug is dextromethorphan, not commonly used in India. So this is just the last list where which other drugs can be used as an adjuvant drugs. So skeletal muscle relaxants like thiacolchicide, tizanidine, chlorhexazone, neuroleptics like olanzapine, and for nausea and vomiting, antibiotics like sedatives, anxiolytics, and laxatives, in one way or the another, they can be used as for the pain also. So again, the table which I'm showing, which drugs are used for which conditions. For neuropathic pain, we have got antidepressants, anticonvulsants. If there is a colicky pain, we can use antispasmodic. If there is pain due to bone metastasis, bisphosphonates can be used. And if there is a pain due to infection, even antibiotics are considered as an adjuvant analgesics. If there is any pain due to edema or nerve compression, corticosteroids are the drugs. And if there is pain due to muscle spasm or cramps, muscle relaxants are given. And again, in neuropathic pain, we can use NMDA receptor block. So this is the question for you all. I have given the conditions. You have to mention the possible co-analgesics. You can use the chat box to mention your answers. Headache, number one, I will go with headache due to cerebral edema. Which is the possible co-adjuvants or analgesics that you're going to use? Yes, it's very simple, but definitely I just wanted to make everyone engage. Yes, it's the corticosteroid. Number two, for painful wounds. Your time starts now. Painful wounds. Okay. Antibiotics, NSAIDs. Yes. Number three, intestinal colic. Yeah, antispasmodic. You have to understand this why we are mentioning them as a co-analgesics wherever their mechanism is different because it is helping us in pain. Yeah. Whenever there is a pain because of the gastric mucosa. Pain related with the gastric mucosal tear. Hmm. What about gastric distension? Okay. Yeah, PPI are the drugs and antispasmodics. Yeah. In case of skeletal muscle spasm, yeah, PPI definitely is the answer. Yes, muscle relaxants. What about the cardiac pain and esophageal spasm? Yeah. So all of your answers were absolutely right. Yes. Good. So if I've again, I will give you options that you have to choose adjuvants. Can you just mention with A, B, C, D what all are the adjuvants in this slide? I know it's be very easy for you guys now. Yes, Dr. Athira, you're absolutely right. The answer is all. Yes, all of them are the adjuvants which can be used as a analgesics. Yes. So to begin with, we can see that WHO step one drugs will be very sufficient for mild to moderate pain. It can be given with a combination like paracetamol with NSAIDs. And we have to ensure that we are giving a dose that can cover the duration for the night. As according to WHO, it has to be given round the clock. So a sustained release preparation can be given at night, like paracetamol 1000 mg or diclofenac SR. We can add anticonvulsants or antidepressants for a neuropathic pain. If patient is complaining of poor sleep, we have to add an adjuvant which is sedative for the better sleep. Because whenever the patient sleeps well, the pain threshold automatically goes down. So we have to always remember that we are covering that aspect also. And psychological support for his financial and social concerns needs to be considered and needs to be evaluated to manage the total pain for the patient. To summarize, WHO analgesic letter was designed to be used by non-pain physicians. But we still often see that many referrals are still sent to higher super specialty, even though this simpler WHO analgesic letter is still there. The reason, what can be the reasons? We are often, the medical fraternity, they're often to use the drugs because we fear there will be addiction risks. Sometimes we don't know. Sometimes we do underdosing because sometimes we just write the SOS or stat basis drugs. We don't give around the clock medicines, and the timing sometimes is not enough to manage the pain. For example, if we miss the sustained release formulation, patient will wake up in pain at night. And often we see pain as a one-dimensional, and we see the pain only as a physical aspect. We have to remember this kind of management, seeing only one aspect, is not useful for many pain conditions like neuropathic pain, like chronic pain conditions like fibromyalgia. Also, we sometimes think that NSAIDs being in the first step, we misuse the NSAIDs because we think since it's in the lowest step, we can use it whenever and wherever possible without considering the risk factors that can be associated with the using of NSAIDs. Thank you.
Thank you, ma'am, for the wonderful presentation. Now we can have questions. If you have any doubts or questions regarding the sessions, you can please unmute and ask, or you can use the chat box.
Anyone has any doubts, they can unmute and say, or they can use the chat box. We have.
Hello, ma'am.
Yeah.
Hello.
Yeah.
Ma'am, this diclofenac is a selective COX-2 inhibitor. And how is the local action comes from like diclofenac?
Again, from the systemic absorption only, sir.
Okay.
Yeah.
Ma'am, one more doubt is this with thiocolchicoside, right?
Yes, the muscle relaxant.
Okay. Any topical application is there for that?
Thiocolchicide, I'm not sure it is there, sir. Usually the NSAIDs are used as topical, not thiocolchicide has any topical effect which is seen.
Okay. Last question. This
Yes.
capsaicin also. Intraoral preparations are there? Intraoral application, capsaicin?
Capsicum, no. Capsicum is only for the topical and only for the neuropathic.
I meant intraoral topical application.
Intraoral is not there, sir.
I meant like a mucosal application, not a skin application. Is it possible to use it mucosal?
No. We have to remember always whenever you are using any patches like lignocaine or capsicum, we have to make sure that the mucosal integration is intact because it can lead to more systemic absorption and more systemic toxicity. So whenever we are applying these patches, we only have to apply on the intact skin, not on the mucosa.
Okay. Thank you, ma'am.
Yeah, thank you, sir.
Hello, ma'am.
Yes, yeah.
Ma'am, how long lamotrigine can be used for neuralgia cases?
Uh-huh. Sorry, I didn't hear you well.
And how long lamotrigine can be used for neuralgia cases?
Well, it depends upon the how the patient is responding, you know. If you're saying how long, that depends upon the patient response to the drug. If we see the patient is responding well to the drug, we can continue. And if we are seeing no benefit in continuing the drug, we might have to titrate and stop. It all depends upon the patient response to the drug.
Thank you.
Yeah.
Ma'am, there is a question in the chat box. If a person develops gastritis to all NSAIDs, including paracetamol, what is the next drug of choice for pain?
Okay, so definitely if the patient is developing gastritis, I believe then we have to find some other alternative. Usually with paracetamol, gastritis doesn't occur. I believe if the patient is developing gastritis to the paracetamol, we have to go higher up to the other painkillers. Selective COX, they have found to have a better gastric side effect profile. So we can, number one, go with the selective COX drug. Yeah.
If the patient is not responsive to lamotrigine for almost 1 month, what should else be done? What else should be done?
I believe then the next point is reassessing the patient's pain, finding the total causes of the pain, reassessing the patient again, and can you just little elaborate more so that I can give the better answer? What is the diagnosis you are thinking in the mind for the
Okay,
patient?
ma'am. I had a patient who had trigeminal neuralgia.
Okay.
Okay, so the patient came to our OPD with a history of 2 months pain. So we took an FCPM and we found that the number for annum was almost very close to the alveolar crest. And we put the patient on tab lamotrigine in a tapering dose for almost 4 weeks. Even after 4 weeks, the patient was not responding to it. The patient actually he had aggravating pain even after that. So we sent the patient for an MRI, and the MRI report came down as the patient had trigeminal neuralgia, deep division. And so the patient was also not willing to take lamotrigine after 1 week, after 4 weeks, that is after 1 month, because the patient had developed serious dizziness and patient was almost tired. He told us that he was feeling very discomfortable. He's feeling almost very fatigued every time. So in such cases, what can be done?
Okay, so if the medical management is not able to manage well, definitely there are other drugs like carbamazepine, which are used as a first line of drug for the medical management. You can try with the other medical management, which are used as a first line drugs like carbamazepine and anticonvulsants, not if the lamotrigine, and increase the dose. And if patient agrees, you can try for the interventional therapy. Now, for trigeminal neuralgia, there are so many interventional therapies which are coming up that are showing very good results. Radiofrequency ablation is there. There is Gazerian ground radioablative therapy also. There are so many interventional therapies that has come up. So if you believe, you can try for the medical management first, like using the carbamazepine or other anticonvulsants. You can start him on that, increase the dose and see the response. Simultaneously, if you feel that the patient pain is so severe, that you don't think that patient is going to tolerate or look for any drugs, you should definitely go ahead with the interventional pain management in such cases rather than medical management.
Thank you, ma'am.
Yeah. There is one question by Dr. Neeta that for how long do we observe whether the adjuvant is effective? Wait 1 second. How long we observe whether the adjuvant is effective or not, so that we can go to the next step. So usually adjuvants are given along with the other analgesics. Definitely we have to give at least for 1 week or more to see whether it is getting benefited or not. Or I think whenever I believe, rather than waiting for a week, we have to reassess the patient every 24 hours to 48 hours. Usually with adjuvants like steroids and all, we can see the effect within 24 to 48 hours. But if you're seeing any other adjuvants like antispasmodic drugs or something, we have to reassess after 24 hours. And even if patient is not improving, you can increase the dose again after 24 hours and again reassess the patient within 24 hours again. Even if after 72 hours, the patient is not showing much response to the adjuvant specifically, either you have to change the main analgesia management mode, or you can change the adjuvant therapy also. Whenever we are trying to look for the pain management, it has to be assessed maximum by 24 hours, if not 24 hours possible, at least by 48 hours. I hope that question is clear, Dr. Neeta. Answer. Can I go ahead with the next query? There is a question by Dr. Victoria. I'm not able to see the chats which are coming later on because I'm going step by step. If your doubt is not clear, you can unmute and please ask. Dr. Victoria is asking, how do we relieve the side effect of TCA and gabapentin like dizziness on caregivers? Yes, definitely. This is the thing which I mentioned during the class, that it is not, we cannot relieve the side effect, but definitely we have to counsel them beforehand. It makes a lot of difference when we are telling the patient already that they are going to see these side effects. That makes a huge lot of difference. So you have to always tell the patient in beforehand they are going to have such side effects beforehand, but at the same time, what you can do is timing for the painkillers, timing for these drugs. For example, you can give tricyclics and carbapentins during the night time to begin with, and then you can increase the dose of carbapentins to the PT and TTS dose, whereas you can continue the TCA dose to the night time. You always, if the patient you feel has got a very low threshold for the side effect, you can start with the low dose of the drug. And again, you have to counsel the patient. These side effects will go in 1 to 2 weeks. So it is only the matter of 1 week that the side effects will trouble them the max. And again, by 2nd or 3rd weeks, these side effects will probably go down. For TCA, usually they have lots of complaints of what you see as a dry mouth also. So you can just tell them for that to keep them well hydrated. Whenever we are giving these drugs, we can tell them to hydrate well. And again, counseling. Do we have mucosal patches as analgesics? No, we don't have mucosal patches as analgesics, especially for radiation mucositis. We have got oral viscous preparation, like local anesthetic preparations as a viscous, which they can gargle and use as a analgesics for the radiation mucositis or any oral mucosa. Definitely, we have got ointment which contains the lignocaine concentration for these kind of issues. Whenever there is some erosion and painful oral ulcers, we can use those ointments, not patches. Have I missed any? Oh, there is one more question. Can we use for analgesic patches for conditions like cervical spondylosis? We have to remember these patches are usually recommended for if you are thinking that talking about lignocaine patch and all, it is not given for conditions like spondylosis. It is only used as a recommendation for what? Neuropathic pain, where especially the herpetic neurology or peripheral neuropathic pain, not for the conditions like spondylosis. In that case, you have to start with the oral treatment. And for local application, there are always the local ointments if the patient has concomitant, the muscle spasms. That is how you can use that. We definitely have diclofenac patch if the patient is not tolerating well orally for any NSAIDs, as previously there was one question. We can always use as a transdermal patch because it has got less systemic side effect profile. What's the time? It's 6:06. If you don't have any other questions, can we go ahead with the case presentation, Sangeet?
Yes, ma'am. Yes, ma'am. We can move on to the case presentation. So,
If there is any question in the chat box, I will just have it. I don't think there is any question. If any other question comes, yeah.
So today our case presenter is Dr. Mary Rose. Ma'am, welcome for presenting the case presentation.
Thank you very much. Am I audible?
Yes, ma'am, you are audible.
Okay. Thank you very much. Starting off with my case presentation. Next slide, please. A 51-year-old female lady. Next slide, please. Patient reported to the department with a presenting complaint of multiple recurrent ulcers in the mouth for the past 1 year. Patient experiences pain in the oral cavity and has difficulty while eating the food whenever ulcers occurred. Next slide, please. Yes. Coming to the history of illness, the patient reported history of recurrent vesicles on the skin and oral cavity prior to the formation of ulcers, and the patient is under regular follow-up for the last 1 year. The patient had a history of CVA 10 years back, and she's under medication. She is hypertensive. There is no known drug allergies. On general examination, she was moderately built and nourished, normal gait and posture. No, there was no signs of pallor, jaundice, cyanosis, clubbing, or edema. There was a single enlarged submandibular lymph node of about 1 into 1 centimeter size on the left side, which was firm, mobile, and tender on palpation. On the skin, multiple scarred lesions were present. Hyperpigmentation was noted on the skin of both hands. There were no active lesions present at the time of examination. Hair, nails, eyes, and ears were normal. The vital signs, the patient was febrile, pulse of 70 per minute, BP of 140/90 millimeters of mercury, and respiratory rate of about 16 per minute. On the review of systems, all were within normal limits, except that the patient gave a history of palpitation while climbing the stairs. Intraorally, multiple ulcers were there involving the entire oral mucosa, which included buccal mucosa, palate, lateral and ventral aspects of the tongue, and floor of the mouth, with an erythematous area in the periphery, and which all were covered by necrotic slough. There was severe tenderness on palpation, and Nikolsky's sign was found to be positive on clinical examination. Investigations were done, which included biopsy and direct immunofluorescence, which were all suggestive of pemphigus vulgaris. Treatment in the first visit, triamcinolone acetonide 0.1% was given for topical application thrice daily for a period of 1 week. Clotrimazole troche 10 mg was advised to be dissolved in water, swish, and spit twice daily for 1 week. Nutrition supplements were also prescribed, and benzidamine hydrochloride 0.1% mouthwash for local application was also advised. But once the diagnosis was confirmed as pemphigus vulgaris, systemic steroids were started, that is prednisone on 20 mg BD for 1 week, and the dose was tapered accordingly. Clotrimazole troche 10 mg was advised to be dissolved in water, swish and spit for twice daily for a period of 1 week. Nutrition supplements were also prescribed, and benzidamine hydrochloride 0.1% mouthwash for local application was also given, and the patient is under regular follow-up. Regarding the psychosocial aspects, she's a homemaker living with a daughter and her family. Her husband passed away 2 years back and she has financial constraints. The main concern was regarding the difficulty while eating food whenever she had ulcers, or definitely she had pain and discomfort, along with the other thing means like she had financial constraints, and always the recurrent ulcers in the mouth makes her apprehensive. To summarize, a 51-year-old female patient reported in the department with a chief complaint of multiple recurrent ulcers in the mouth for the past 1 year. The patient gave a history of recurrent vesicles on the skin and oral cavity prior to the formation of ulcers. The patient is under regular follow-up for the past 1 year in the department. The patient also had a history of CVA 10 years back and she's under medication. She's also hypertensive. On general examination, it was within normal limits, except that there was a single enlarged submandibular lymph node of about 1 by 1 centimeter size on the left side, which was firm, mobile, and tender on palpation. On the skin, multiple scarred lesions were present. Hyperpigmentation was noted on the skin of both hands. There were no active lesions present at the time of initial visit examination. Vital signs were all within normal limits, except for the increased BP of about 140/90 millimeters of mercury. Intraorally, multiple ulcers were there involving the entire oral mucosa with erythematous area in the periphery and covered by necrotic slough, which was always tender on palpation. Nikolsky's sign was positive. The investigations were done, which was suggestive of pemphigus vulgaris. During the first visit, topical steroids, topical anesthetics, topical antifungals, and nutrition supplements were prescribed. Once the diagnosis was confirmed as pemphigus vulgaris, systemic steroids was given with an initial dose of 20 milligram daily for a period of 1 week and then tapered accordingly. Along with that, topical anesthetics, topical antifungals, and nutritional supplements were continued. And the patient is under regular follow-up in the department. The main discussion points are: 1, how to address total pain in this patient. 2nd, how can we treat pain in this patient. 3rd is how to counsel regarding the problem of recurrent relapse during the follow-up period.
Yeah. Thank you, Doctor, for the nice presentation. Before we go ahead, I would like the participants to come ahead and address the first question that you have mentioned in the discussion point. How to address the total pain in this patient. Anybody among you can unmute and please go ahead. So we know that the patient has lost her husband 2 years back. That is the number one aspect in the social and emotional aspect. And the number 2, she's living with her daughter and her son-in-law, and she has got some financial constraint. What do you think? What else can be done when we're thinking about total pain? Anyone, if you don't want to unmute, you can just put in the chat. Okay, Dr. Nita says stress reduction. Yeah. How will you suggest the stress reduction? Dr. Nita is right. This condition, I believe it is, I'm not well versed with the skin dermat conditions. It is an autoimmune condition where the environmental factors are the stress triggering factors, if I'm not wrong. So definitely the total pain, managing the total pain will be a very important and vital point in managing the whole condition in her condition. Stress reduction is definitely one of the major parameters we have to focus on, because environmental factors can trigger and cause recurrence of this condition. And later on, managing this condition slowly becomes very important, very difficult. Yeah, Dr. Vijay is saying we can add angeletics. Definitely. We can we can use pharmacological management if the patient you feel the patient is anxious. If the patient is anxious, you can add anxiolytics. But what about she says she's not anxious? Because yeah, Dr. Athira is totally right. We can start with her counseling regarding the autoimmune disorder. Number one point in that is the education. We have to educate her about the condition. We have to educate her about the triggering factors. We have to, if possible, if there is no psychologist along with you, you can ask with a simple question: how is she feeling lately after her husband's death after 2 years? How is she feeling about that? How is she doing at her daughter's home? If she had come all alone in the visits for her condition, you can tell her to bring her daughter next time and to address this issue with the daughter as well, to understand the situation and the emotional aspect better. Dr. Rakesh is absolutely right. We can go ahead with the psychological assessment and the counseling for her. And in that, to manage the total pain, we have to first identify what are the actual issues with her. Definitely, she is anxious regarding her recurrent ulcers, and because that will lead to a reduced quality of life. So definitely, we have to focus on that. We have to include her family members in this. If she is not feeling emotionally right about the situation, I think including the family members, including the caregivers, is very important in tackling the emotional aspect of the total pain, because that is how the support comes from. She is going to get support from. And second is in addressing, again, I'm still at the question number 1. So this is how we are going to manage the total pain in this condition. Total pain, definitely we are going to do a psychological assessment if possible, and if it's not possible, you can ask her to bring her daughter next time to the visit. You can go ahead with her. If she is reluctant to talk about her emotional aspect, you can talk with her in front of her. You can make both of them sit and educate them about the status of the condition, and you can talk about, definitely you have to stress on the factor that the environmental stress factors are going to increase this kind of pain, and most importantly, what kind of food she's taking, because there's some food items also which can trigger this recurrent acid ulcers. So we have to modify her diet also. Might have to modify her diet also. Along with that, she has to take care of her oral hygiene. This is how I believe we can address the total pain in this patient. If anybody has anything else to say, we can definitely go ahead with the question number 2 in the discussion point. Yeah, Dr. Raj, steroids have anti-inflammatory and analgesic property. Definitely, it was already started, if I believe, for her. Steroids were already there. And if possible, you can add for a short-time course of the non-steroidal anti-inflammatory drugs also, if she tolerates that too. But very important to remember that whenever you're using 2 drugs which has got as a GI risk factor, we have to reduce the doses of the NSAID, because both of them can lead to the gastric erosion. So when we are prescribing NSAIDs to these patients, we have to be very careful with the dosing. So just be careful with the NSAIDs dosing in these patients. Question number 2, how can we treat pain in this patient? I think a few of you have already spoken about that aspect. If you are just thinking about the physical aspect of the pain, we can, steroids were already there. I think local applicant with the lignocaine was already given to her. I think NSAID was not given. If she does have an acute pain, you can tell her to take a short course of NSAIDs with the reduced doses for her. Or we can go ahead with some gastric sparing NSAIDs for her, because she's using steroids also, and topical application. Along with that, managing pain, definitely, again, it has to be, oral hygiene has to be there in managing pain. Okay. And I believe, coming to the question number 3, how to counsel regarding the problem of recurrent relapse during follow-up. I think if you address the total pain, this question will automatically get answered. Because whenever we are managing the total pain, we are already will be counseling her. What are the problems for the recurrent relapse? That is the stress factor, environmental factor is going to definitely trigger her pain. So the first thing will be the education, as I already said. It will take for her some time to come in terms with that thing, because it is going to affect her daily life with these oral ulcers. Her dietary intake will be reduced with this. So definitely we have to manage her diet also along with all of this. And again, emotional and psychological support, just being a patient listener, believing her, especially with this kind of condition. We often will feel that it is not something very major, and but for her it is something, it's going to affect her majority of the life. So we have to show that comfort to her. And definitely the regular follow-ups, I think, are definitely going to, a regular follow-up for her will definitely going to, I think, help her. Maybe it can be a telephonic follow-up that can do. Yeah. Listen and reassurance, definitely. I think for all autoimmune conditions, that plays a very important role, because autoimmune condition is something very less understood. The mechanism is still not understood well. So definitely listen and reassurance.
Thank you very much, ma'am.
Yeah. Anyone else wants to add up something?
Ma'am,
Sorry.
you're muted, ma'am.
Yeah. Sorry. I think we still have some time. We can wait for some queries and some insights from other people.
Sure, ma'am.
We'll wait for a few more minutes before anyone's input can come.
Do I need to keep the presentation on?
No, I think we can stop the presentation part. Yeah. I'm just waiting for questions and queries to come up. We can wait for 1 more minute, Sangeet.
Sure, ma'am. Sure, ma'am.
Yeah.
Ma'am,
Dr. Raj, please go ahead.
yeah. Suppose we have hepatotoxic as well as renal impaired patients. In such situations, how we can manage pain?
Yeah, so in such situations, a patient will definitely will be in quite in a what you can say, not in a good state. Probably will be in the ICU or somewhat. So you have to decide risk versus benefit ratio, a risk versus what is benefit for the patient. So in such cases, if we feel that patient is in much more agony rather than focusing on his organs state, you can start with the opioids, which are short acting in such conditions if the patient is hospitalized, if it's so. Or we can definitely start with him fentanyl opioid, we can say, in such situations. Definitely not NSAIDs. If we can go with a low dose of paracetamol, if after discussing it with the patient or the patient relatives, and they prefer that patient should be more comfortable, definitely you can start with a low dose of paracetamol, or you can start with the opioids straight.
Thank you.
General question by Dr. Ronit. A dentist work at palliative care centers to treat polycystic outside the oral. Does it fall within the scope of dentists to do the scheme? See, if you think that pain management, see, if you're working at the palliative care center to treat the pain, you can treat definitely the pain. If you know the mechanism of pain and how, from where the pain is originating. But if you are doubtful regarding the origin of pain, and if you're not able to understand exactly the mechanism from which the pain is arising, it is always preferred that a specialist can come and see. But if you believe that that pain is because of some local lesion, you can definitely manage the pain, because WHO ladder was originally basically for the general physicians only. It is because it is very simple to use and effective. But yeah, definitely, if you don't know about the use of the opioids, you should not use opioids. But definitely, in recommended doses, you can use NSAIDs and paracetamol or other adjuvants. There's a comment by Dr. Athira about the flopidine. Sorry, Dr. Athira, I'm really not sure about this question. I might have to go back and check and get back to you for this query. Sangeet, can you go ahead and note this question, please?
Sure.
Yeah. If there is no question, I think we can stop the session, if that's okay, Sangeet.
Okay.
Yeah.
Do you have any questions, participants, regarding the session? Okay, that's it. Thank you, ma'am. Thank you for the wonderful presentation. Today's session. Thank you, Marin Jose, for presenting a wonderful case presentation. Thank you all for participating actively. Thank you. Let's see in the next session. Thank you. Bye.
Thank you, everyone. Good day.